want to reemphasize about what kind of testing we're talking about. This is RNA diagnostic testing. That is the platform that was built to respond to this epidemic. It is the same platform that we utilize for HIV viral loads. And so many HIV clients have also given up their space on the machines to have these tests run for all of Americans. This assay is complicated. It's not like an assay that you have for your other diseases, your strep test or other diseases like that. This is a very complicated assay that requires a lot of technical oversight, and it's part of the reason why not all 100% our machines are running at full capacity, but we had great discussion with the lab directors about that. Every day more are brought online, and so, but I think we have to create expectations of what the daily test rates will be. Last year, we probably did 3 million HIV viral loads or 4 million HIV viral loads as a country. We've done over almost 2.2 million in 4 weeks. So this is unprecedented in what we have to do. I think that's why we're working very hard for 2 pieces, and I want to make sure that people understand testing is just part of our strategy. The other part of the strategy has to be this syndromic and influenza-like illness where there's an alert to an illness, and so that we're surveying where we know the most vulnerable cases have appeared. And the great call that I had with the mayors and with the health officials yesterday and mayors today, a lot of the rural areas, their primary, and as it was in Washington and California, was at the nursing homes. So the issue is to build a testing strategy that speaks to our strengths, of laser focusing a strategic approach to testing when we know what our volumes are, and they increase every day, but we have to be realistic about what the volumes will be a week, 2 weeks, 3 weeks from now, and combine that with strategic surveillance so that we're testing symptomatic people and their contacts very quickly to go back to contact tracing, utilizing our complete strategy. And I think we're very much interested, and it's why the president 3 weeks ago really put us on getting an antibody test. And I think I called from the podium for our university colleagues and hospitals to begin an ELISA-based test, because that's a blood draw, but we really wanted a finger prick to make it easy and deployable. That's what's being worked on now. Of course, we don't want to promise until we have it, because I think we deserve that. The American people deserve that, to have a test that is efficient to let people know who's been positive for immunity. That's critical to epidemiologists and public health officials, to know what the penetrance of a virus was into a community when all you're seeing are the serious cases and testing the most symptomatic. And so that's a question that we still have. Is this the tip of the iceberg, or is this half the iceberg or 3/4 of the iceberg, what we have seen to date? And we have, I just want to complete the thought by saying, in the areas where we had an outbreak, these large metros, Louisiana, Denver, Detroit, Chicago, New York, New Jersey, but per capita, we've done more tests than any other place in the world. That was intentional. We focused the test where the need was the greatest and the burden of disease the greatest. And now we're trying to really see how strategically that very valuable resource can be utilized around the countries to create a mosaic of testing combined with surveillance.
Can I ask you about the new federal projections? There's new reporting today that new federal projections suggest lifting.
I'd like to ask you.
I'd like to ask you, if I can, about the new federal projections